Yep, looks good.
Yeah, thank you. Just to repeat, Shaun Respess. I am a recent graduate and now current instructor with the Department of Philosophy at Virginia Tech. Excited to be here talking about this because it's very much still a work in progress and something I'm looking to cultivate further, especially on the practical side. I'll apologize in advance for my strange glances. I'm going to stick to my notes as much as possible because I have a tendency to ramble if I don't. The primary goal here is I'm going to share kind of some of the motivations and initial underpinnings of the project, because I do specify it in mental health with regards to this talk, but I'm curious to see if this direction in general has promise, and if so, how versatile the application can be. So the framework that's at stake today, it's something I'm tentatively calling the care abilities approach. I'm not married to the name, but right now it's the best thing I have available to me. This is a reconciliation between the analytic structure of the capabilities approach, as initially developed by Amartya Sen and Martha C. Nussbaum, and the relational considerations of care ethicists, largely driven from the broader category of feminist ethics. These two literatures have overlapped at several points, mostly in kind of minor critiques, but based on the research I've done so far, they've never really formally been intertwined. So I do think that once formulated, it can be used for several conversations concerning well-being, maybe resource distribution, flourishing more explicitly. But I want to kind of first explore it within a particular problem space. This idea for merging these two literatures mainly came in response to the significant amount of dissatisfaction I was seeing for many people with respect to the language and clinical endpoints used in evaluations of mental health, particularly those stemming from the biomedical model. To state this approach very briefly, a medical model asserts that there's a dichotomy between mental health and mental illness, of which one is the absence of the other, and usually pathologizes issues within an individual. So an illness presumably stems from biological causes, such as imbalanced neurological chemistry, whereas a disorder stems from a problematic series of behavior that an individual has. Now, this is a little outdated in terms of an exclusive model. Practicing clinicians do not necessarily adhere to this model as rigidly as they once did, but the terms and general approach of biomedicine are still widely utilized in the diagnostic tools we have and the public communications we issue. More recently, we have begun to more readily identify structural stimulants and limitations which may traumatize individuals, thereby affecting their mental health. These observations have driven many towards a hybrid, what we call biopsychosocial model, where we evaluate a person's responsiveness to various intrinsic and extrinsic factors. In other words, we're thinking quite directly about their capabilities. Whether intentional or incidental, the language of capabilities is widely accepted in mental health literatures. For instance, the World Health Organization offers this definition, which is recurring in the majority of facilities and research centers we have across the globe. Quote, it's a state of well-being in which the individual realizes his or her abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community, end quote. Like its biomedical predecessors, this definition has been criticized for being too individualistic, for overemphasizing choice, and for assuming without sufficient qualification ideas such as productivity and normalcy, which you're seeing there. Interestingly enough, for me, the same criticisms have been levied against the capabilities approach as an analytic framework. My hypothesis here is rather simple then. Modifying the terms and structure of this framework can help us alter our perceptions of mental health to better reflect that conventional understanding of well-being. So those are kind of the motivations and broader ambitions of the project. Here's the actual kind of theoretical work behind it. So both the capabilities approach and care ethics come from a place of reckoning with existing vulnerability. In other words, they are most concerned with ontologically and politically induced limitations placed on particular individuals because of distinct differences. What we understand as precariousness is something we all live with. It's persistent threats of hunger, illness, harm, and so forth. Precarity is instead those vulnerabilities which are imposed on persons by the social or cultural order, such as higher rates of pollution or economic inequality in certain areas, or even the absence of accessible spaces. What both theories are interested in that at some level is the varying level of vulnerability persons have by nature of their relationships to specific resources, environments, and other persons. The capabilities approach uses this question to critique distributive justice models and liberal philosophy primarily. In a famous critique of the philosopher John Rawls, Amartya Sen, for instance, notes that quote, Rawls takes primary goods as the embodiment of advantage, rather than taking advantage to be a relationship between persons and goods, end quote. Equality, therefore, is partially a matter of a person's abilities to effectively utilize resources. Capability theorists such as Sen and Nussbaum normally focus on one's internal abilities, like those we may focus on because of age and or experience, like the elderly or children, or because of physical disabilities. In many cases, this theory is used to examine poverty relief and the ability of a person to epistemically and practically utilize the full potential of a resource. So for example, Sen provides the famous comparison between the starving monk and the fasting child, both having the primary need of hunger, but one clearly in a better position to meet that need, if they so choose. One is just simply foregoing that choice. This model was designed to account for circumstantial differences while also preserving free choice and adaptability. Nussbaum in her account highlights choice more explicitly, and we should protect one's right to choose their own ends and to avoid coercion. This is like the underpinning of her framework. Though I consider the approach on its whole to be a significant upgrade in terms of outlining authentic and achievable welfare across diverse persons, especially given Nussbaum's more explicit list of what those might look like, there are still several components here which might prove to be rather limited or under-theorized if we don't dive further. Critiques of the approach largely center around its steadfast commitment to methodological individualism, predominantly as it concerns one's autonomy. The doings and beings one has reason to value are a matter of one's personal preferences, and their capabilities are thus reflexive of their capacity for individually achieving them. Critics such as Dean and then Burkhardt, shown here, argue that this allows the approach to indirectly apologize for structural failures, including those by late capitalism, and to allow further exploitation by justifying how even one's adjusted achievement is primarily a reflection of their choices and or pursuits. So under this model, if we have higher states of precarity towards certain populations, certain individuals, or just in certain circumstances, we tend to still use the capabilities language to assess the resiliency of persons, rather than to direct our attention more towards the relationship with those structural failings. For the purposes of amendment here, care ethicists can rephrase the logic of autonomy to be more relational, specifically by incorporating the empirical and normative premise of dependency. To be dependent is a basic feature of our mortality. So in relation to what we just talked about, it's a vulnerability which requires the response of another or multiple others. To borrow the words of Ebba Feder-Kate, what unites us as creatures is that we are all some mother's child, for better or worse. From an ethical standpoint, this means that relations, not simply individuals, are the units of moral concern. They are the atom of interest here. For no being has or will ever exist in complete isolation from the vast network of relationships to which they are a part. Using care ethics, we may instead consider how relations are empowered and sufficiently capable of achieving diverse functionings. Within a framework of care, we begin to think beyond what the one requiring or receiving response can do, and rather ask what the unique responsibilities are of those in the fluid associations by nature of the relationships they're in. From here, values like attentiveness, responsibility, beneficence, and competence adopt new meanings. And I have that note there that we have a conception or even maybe values attached to certain types of relationships, regardless of who the individuals in that relationship are. So before I do some more exploration, I should say, with this and some application, here's my tentative definition of care abilities that I'm still working on. They are the capabilities of a relationship or set of relations to foster care, specifically as such care facilitates sufficient need fulfillment, flourishing, the preservation or development of harmonious relations, mutual respect, reciprocity, and empathic responsibilities. And of course, I have a nice image of penguins there to hopefully brighten up your morning, and because I've always been fascinated by their interpersonal dynamics, thinking relationally. A relational approach to capabilities appears sorely needed in discussions of healthcare specifically. In their analysis of patients, Entwistle and Watt assert that, quote, relational thinking about capabilities can readily accommodate the idea that there are many important senses in which the ways others treat us enable us or not to exhibit the characteristics, as well as to experience the social status of persons as ethically significant, end quote. According to their findings and their diverse study of patients, their patients fundamentally belong to complex social networks that warrant unique attention, respect, compassion, and material support, understand within very particular context. None of this is going to be unfamiliar to practicing clinicians. They already know this usually. When thinking about their abilities, we assess their autonomy by responsiveness and to, and then an inclusion in that kind of caring relationship, along with a potential ability to eventually care for themselves and maybe extend that care to others. This view is built on the realities of dependency, since the capabilities of many persons are not possible without the care of others. Returning to to a theorist like Kate, she notes how for many disabled persons, care is the mechanism by which they actually pursue their conceptions of the good life, not an obstacle to those pursuits. Furthermore, if we understand choice to be solely agential, we can re-energize problems of paternalism in healthcare, which is usually the core source of many problems that we've been looking at over the past 50, 60 years or so. As Veach argues in his book, Patient Heal Thyself, when patients are treated simply as consumers of our medical interventions, we expose them as uninformed decision makers and alter our methods to invest more in advertising than scientific deliberation. Because of radical differences in epistemic access, we also expose patients to the very coercive influence that a principle of autonomy was meant to protect. A failure to grasp the complexity of the connections diverse individuals have can result in that paternalistic nudging that, when justified by a logic of choice, stigmatizes those in disadvantaged positions. Again, they have chosen this problematic form of care for themselves in some way. Rather, I want to argue that care abilities requires us to externally and internally engage with the power dynamics of a given relationship, which allow particular groups or persons to differentially exercise autonomy in the delivery of care. So with that in mind, I want to spend my remaining few minutes, my time, going back kind of full circle to mental health, like what many of you probably care about with respect to this talk. To start, I believe this language can promote greater empathy when it comes to neurodiverse patients and those who identify quite strongly and sometimes positively with the disorder. What Mohammed Rashed refers to as mad identity, or the larger movement you're seeing there, which is mad pride. Some might claim that pride in one's depression or schizophrenia, for instance, might be what we call an adaptive preference, one that is irrationally formed as a symptom of coping. Scholars like Polly Mitchell, however, note that persons without these disorders typically underestimate health gains, overstate health losses, and misread experiences with pain or pleasure. This is also known as the disability paradox because of its prevalence in those circles. Therefore, they discriminate against those whose neurodiversity might make them more aware and or more enriched with respect to the relationships they actually have. Understanding these types of associations and demands can allow us to empathize better with their dependency and thus respond more appropriately with what they actually require and need. By embracing dependency as a whole, claims of irrationality may also lose their merit, which is a big hope for me. A more direct application might be the ability of persons to choose and utilize treatments within relationships which have differing levels of access. Accounting for the professional gatekeeping that occurs with different types of medications and therapies certainly seems warranted. It is not so much a matter of expanding choice as much as possible, but at looking at the kinds of relationships one can have and their affiliated options. This is a part of the ongoing concern with accessible clinics, therapists, psychiatrists, and so forth. One's capabilities here also reflects their potential to build, navigate, and or terminate certain relationships, which is very much salient when we're looking at conversations of therapeutic fit, for instance. In my view, not enough attention is really placed here. Nevertheless, this approach still preserves individual preferences by maintaining room for patients to select treatments, even if they are not the most efficacious, like certain medications have proven to be. What matters is working through the relations of power which could materialize those preferences in the first place. The more essential question for a care abilities approach remains the sound articulation of clinical endpoints. What exactly does it mean to be healthy, ill, well enough, and so forth? I largely turn back to care ethics for thinking about this. In opposition to the biomedical model, we would demolish a dichotomy between health and illness in favor of a spectrum of need fulfillment and flourishing understood in terms of care abilities. One is persistently in a position of maintaining and developing their mental health, but never quite fully healthy. Serious impediments do not necessarily demonstrate problematic behavior or physiology, but indicate a deficiency in primary need fulfillment, whether that would be a reflection of the individual's relationship to those needs or greater structural problems. Flourishing just happens to be on the more favorable end of the spectrum, even though most of us are going to occupy a well enough space on the spectrum. Now, this has both objective and subjective components to it. It's part of a larger theory and philosophy called flexible objectivism with respect to welfare. I prefer to lean on Kate and other ethicists' language here, though the details, in my opinion, should be worked out by those more closely related to the problems at hand. So with respect to each medical field. So for the objective side, quote, a person flourishes when the person has or has access to or can strive to attain, either on her own or assisted by another, the things an individual truly cares about, in the sense that these are the things that make it worthwhile for a person to get up every morning. And the second condition being that the things that the individual truly cares about that are genuine needs are met, That is, needs which, if they fail to be met, will result in a genuine harm to the individual, and legitimate wants are satisfied. That is, wants that can be met without sacrificing the equally legitimate wants of another. On the subjective side, that flexible component of the theory, persons must also have the sense that we are flourishing, sensing that we are living the life we want to live, having a sense of well-being as we see ourselves conceive of well-being. So it's not simply that we have the subjective list of careabilities to meet, but once they're met, we have a general understanding that they are being met and that it is something that also fits within our interest. What I'm offering here on a whole was an ethical framework to really get us started, to maybe set a foundation. But I want to continue developing this in an interdisciplinary capacity with those better trained to observe outcomes. That being said, I will note that both inside and outside the clinical boundaries of mental health have found the current state of symptom evaluation and diagnosis to be highly troublesome. So I believe this could actually fill a real need and maybe even extend to other areas. The next stages of this project, in my mind, will be more application driven, which should also provide an excellent opportunity to flesh out some of the premises. But I would love to hear any and all thoughts you might have, both on the applied and the theoretical side here. So thank you.
All right, thank you very much, Shaun.
Thanks.
I see we did get Salon A to connect. If there's anyone online, I think there's a laptop in there. You guys can either unmute, or if you want to ask a question, you can certainly post it in the chat. Are there any questions off the bat here? Well, one of the things I was thinking about is for care ethics, a lot of times we go back to trying to make people whole in different components of flourishing and living the good life, and what those needs and expectations are going to vary. What do you have to say about where people don't have the same access, or so accessibility in terms of, say, disabilities that may impair them or prevent them from doing similar tasks, or differing socioeconomic status?
Yeah, that's an excellent question. My response is primarily, I think, going to be a value statement, because I see, for example, the disability argument. I primarily see that as a relation of misfitting, using kind of Rosemary Garland Thompson's phrase here, in the sense that I'm thinking very relationally about, it's not necessarily always an ontological difference, something we're born with, differently able, disabled kind of conception. And it's not necessarily just about structural impediments on certain groups, which I certainly think that exists, but what is the relationship between individuals to their environment? For instance, we typically think of, someone, maybe a wheelchair user, being quite friendly to many types of ramps as opposed to stairs. But based on the nature of those cuts, that actually could produce a more complicated fit, and the relation to the structural space. And I think neurodiversity works in a lot of ways. I'm very much subscribed to the idea that, for example, if you've met one person with autism, you've met one person with autism, and there's a lot of ongoing development that needs to go there. So a lot of this is very much relationally thinking in terms of misfitting. I think socioeconomic circumstances fit well into that flexibly objective scenario, which clearly we think people should have the means, whatever that means, resources to, feed themselves, right? Have shelter, participate in jobs that we consider to be fulfilling. But the terms on which they understand, what that means is going to be rather, diverse, right? Nutrition, we might seem to have a relatively stable set of categories, but we know that bodies are different and they're constantly trying to adapt to those different types of spaces. I don't necessarily think that increasing choice always is optimal in those scenarios, primarily because we are more prone to poor choices or misinformed choices when we do that, rather than stimulating the relationships that constitute those choices in the first place. So for example, in the healthcare sector, I don't enjoy the fact that most people bring options to their doctor rather than kind of cultivate a conversation with them in the first place, for whether it be for medication or a certain type of diet. And I could go all day with this, but I'm mainly kind of providing a value statement on how I observe the relationship itself.
Shaun?
Yeah.
Hi, this is Peter. And
Peter.
I find that in understanding different theoretical frameworks, that it helps to provide various examples. So I was wondering, since you're talking about mental health, if you could explain how your approach, say, would be applicable to a better understanding of whether it's schizophrenia, depression, ADHD, autism, addiction, and other kinds of disorders, how that would compare or contrast with alternative approaches, using those kinds of specific examples. That way I can decide to what extent I agree or disagree with what you're saying.
Yeah, thank you, Peter. It's an excellent question. Definitely part of that applied side that I'm continuing to work on, whether it be in concrete examples, which I prefer, or sometimes just thought experiments. I'll start with one of the first ones you mentioned, which was schizophrenia. And this is coming out of maybe the anti-psychiatry movement in the 1960s, 70s with someone like R.D. Laing or others like him, where they're interacting with schizophrenic patients who are seen to be untreatable. You could provide maybe palliative care or forms of things like that, but you couldn't really respond to them as agents. And a lot of these conversations, even developing into the 1980s, were concerned with, are we providing patients with enough resources to essentially heal themselves? Again, medications being a kind of a template example of that, but also certain spaces. And it's still kind of worthwhile. But what I find interesting about maybe like an R.D. Laing case or others like him was that a lot of the therapeutic healing that was going on came by nature of who was delivering care. Specifically the types of therapeutic alliance they had built. You see this in contemporary examples like a Western Lapland, Finland, and their open dialogue method. The method itself seems to be much more sustainable in treating a number of disorders or things that we consider disorders, but there's still variability with what clinicians are in the room with them. And also with group therapy, what other kinds of patients are coming together. So it's not just, for example, the capabilities approach would assert that those kinds of patients are better suited by nature of how they utilize the resources. They go to a clinic and how well do they, adapt to the space and accept treatment and all of that, when a lot of that is contingent by, the relationships they're forming with other people. So I'm looking at those therapeutic alliances and saying, or do we provide enough, not only resources, but skill sets and epistemologies to inform any and all who might enter that relationship, not just the individuals themselves. When it comes to something like autism, I think we have a lot more, we do a lot more homogeneity than we care to admit, specifically when it comes to, noises and lights and certain types of spaces, which we consider to be rather problematic. But we found that many individuals who might, for example, proclaim to have light sensitivity or audible sensitivity are quite comfortable with loud noises that they're familiar with. They have an interesting environment either to the space or the people they share the space with. So for example, there are many autistic individuals who live in New York City and hate loud noises, but they're fine with subways and certain types of public transport because they've got a unique relationship to those spaces. So I'm using this framework really more so on the descriptive side. What are we missing? What kind of details here are we not unpacking? And can we frame a normative orientation for this? So it's a fantastic question I'm still working on, but I hope that's maybe a start to working through that.
Okay, thank you. And I guess it might be, I might feel a little bit more helped on this journey if there was more, say, recognition of the biological dimensions of that, whether it's in terms of the medications that are used that sometimes are helpful, sometimes are not, right. As well as the etiology of various kinds of mental illness, instead of just how it affects people's lives. Although how it affects people's lives is the reason that they seek help in the first place.
Right. No, granted, I completely agree with you.
Okay. Thank you.
Do we have any other questions or comments? Well, Shaun, you can either use the time to expand on something else that maybe there's a question. I don't know, is there a question you are usually asked or typically don't get asked and would like to address something at this point? Otherwise, we can wrap up since we're almost at our time and we'll go from there.
I don't have really much to expand on, but I do want to take Peter's last point seriously, because this is, actually both questions that you asked, again, thank you for those, are general ones I asked, like show me the application, right? Because I'm usually talking to practicing clinicians, but also how do we account for, how do we consider those intrinsic differences that we know to be rather harmful to individuals, primarily because they tell us it impacts their life. And I think it goes back to that precarity distinction. We're not eliminating the fact that some lives are just made harder by the birth lottery, and that many should have the option to select solutions that provide them more fulfillment, even if it is, contingent with what we consider maybe normalization. Christina Gupta has a fantastic book on this called Medical Entanglements, and she argues that most medical interventions kind of stimulate two problems simultaneously, or not problems, but two claims simultaneously. They'll alleviate individual suffering and they'll reinforce social inequality. And I think a lot of that goes down to how do we help people come to terms with some of their maybe biological or experiential, what they would consider to be, maybe some of us looking in would consider to be deficits in social functioning or physiological functioning. So I want to preserve that. But at the same time, kind of opening up the space for more pluralistic conversations, primarily because though that is true, it isn't the whole truth. And a lot of times we use that to create diagnostic categories. And I found that a lot of, for example, practicing, or not all practicing psychiatrists, but many prominent practicing psychiatrists and psychologists, for instance, are absolutely fed up with DSM criteria that standardize from those kinds of epistemic standpoints when they're really just kind of a part of the puzzle.